Why do we take prenatal vitamins? What's in them? And which ones should you take? If you want the answers to these questions and more, stay tuned. Welcome back, everyone. I am Shawn Vasquez with A Mother's Nature. Thanks for joining me. So when you're planning to become pregnant, or when you first find out that you're pregnant, and even after the baby arrives, it can be really overwhelming with all of the research that needs to be done, all of the decisions that need to be made. So part of the reason that I'm here is to try and alleviate some of that. Over the years, I have done hours and hours of research and have compiled so many great resources and so much information. I'm finally bringing it all together right here. A one-stop shop for everything pregnancy, birth, baby, and postpartum. Now, I want to be sure to mention that all of the information I provide here is evidence-based. Resources I'm using are all peer-reviewed studies, scholarly articles, medical journals, the links to which are all located in the description of the video. However, I am providing these resources and my commentary on them for informational purposes only. If you have any serious medical concerns or questions, you should contact your midwife, your doctor, or a medical professional, as well as do independent research so that you can make informed and educated decisions for your specific situation. So, prenatal vitamins. Why do we even take them? Many studies show that the use of supplements before, during, and after pregnancy can prevent many complications for the birthing person as well as the fetus. Things like neural tube defects, preeclampsia, preterm birth, and many other serious conditions. During pregnancy, many changes take place in the body, and we require increased amounts of many of the vital nutrients that make these processes possible. Now, you're probably wondering, what do these supplements consist of? What are the ingredients? There are literally thousands of different variations and different compounds out there. So many different brands available on the market today. So I'm going to focus on the main ingredients that I see in most of the prenatal vitamins out there. Folate or folic acid, iron, calcium, zinc, vitamin D, vitamin C, and vitamin B6 are some very common prenatal supplement ingredients. Let's break them down one by one. I'll show you excerpts from medical journals and peer-reviewed studies about each one. We'll talk about the pros and the cons, if there are any, and what the recommended amounts are, when you should take them, how often, and so on. So let's dive right in and take a look at what the research says. First up on the list, and what might be the most controversial ingredient, is folate or folic acid. So first of all, why the distinction? What's the difference between folate and folic acid? Folate is another term for vitamin B9, which is the naturally occurring form found in foods. And folic acid is a synthetic or man-made form used in supplements and fortified foods. Folate is really important in our body. It is used to make red and white blood cells in the bone marrow. It helps to convert carbohydrates into energy, and it helps to produce DNA and RNA. It is especially important during times of rapid growth like infancy, adolescence, and pregnancy. First, let's take a look at what the World Health Organization and the Centers for Disease Control have to say about folic acid or folate supplementation during pregnancy. And they recommend daily oral iron and folic acid supplementation with 30 to 60 milligrams of elemental iron and 400 micrograms of folic acid recommended for pregnant women, preventing maternal anemia, puerperal sepsis, low birth weight, and preterm birth. And they do say at the bottom there, folic acid should be commenced as early as possible, ideally before conception, to prevent neural tube defects. And here, this is from the CDC, saying that folic acid is an important part of planning for a healthy pregnancy. The CDC urges all women of reproductive age to consume 400 micrograms of folic acid each day, in addition to consuming food with folate from a varied diet to help prevent some major birth defects of the baby's brain, known as neural tube defects. The two most common types of neural tube defects are anencephaly and spina bifida. Anencephaly is a serious birth defect in which parts of the baby's brain and skull do not form correctly. Babies born with anencephaly cannot survive. Spina bifida is a serious birth defect in which a baby's spine does not develop correctly and can result in some severe physical disabilities. All women, but especially those who might become pregnant, need 400 micrograms of folic acid every day. And then it goes on to explain that every woman needs this amount in addition to consuming food with folate from their very diet, even if she doesn't plan on becoming pregnant. The importance of folic acid happens very early on in pregnancy, within the first few weeks before most people even know that they're pregnant, with several studies showing that we could have very positive outcomes taking supplements early on to prevent these birth defects. They actually passed laws making it mandatory for foods, certain foods, to be fortified with the synthetic folic acid back in 1996. And this is where a lot of the controversy comes in. As with anything, it takes years and years of study to get a well-rounded view of the full situation, weighing all the pros and cons. So is it really healthy for all people to be consuming this synthetic form of folic acid in such large amounts in all of these fortified foods on a daily basis? What long-term effects could this have, positive or negative? And is the artificial folic acid really the best form for all people to be consuming? These studies and reviews aim to answer some of these questions. So this is an abstract from a review in the Journal of Biomedical Science about folic acid supplementation in pregnancy and implications in health and disease. And it says that maternal exposure to dietary factors during pregnancy can influence embryonic development and may modulate the phenotype of offspring through epigenetic programming. Folate is critical for nucleotide synthesis, and preconceptional intake of dietary folic acid is credited with reduced incidences of neural tube defects in infants. While fortification of grains with folic acid resulted in positive public health outcome, concern has been raised for the need for further investigation of the unintended consequences and potential health hazards arising from excessive folic acid intakes, especially following reports that folic acid may exert epigenetic effects. I'll stop there for a second and just explain epigenetics, literally meaning above or on top of genetics. It's referring to external modifications that can happen to the DNA, kind of turning genes on or off. So the modifications don't actually change the DNA sequence, but they can affect how the cells read those genes. And that's what that's referring to. So the objective of this article is to discuss the role of folic acid in human health and to review the benefits, concerns, and epigenetic effects of maternal folic acid on the basis of recent findings that are important to design future studies. And here we have the conclusion from that review, and that says the clinical application of folic acid supplementation intake to prevent neural tube defects has been well proven for the last 20 to 25 years. However, considering the concern with the level of folate concentration following post-fortifications, it is of interest to explore if folic acid exposure in significant sections of the population is influencing other normal biological processes, such as the brain's development. It says studies and careful monitoring of the consequences of folic acid intake in global perspectives will help clinicians to determine a proper therapeutic strategy and the best preventative measures to improve the overall public health. Moreover, to precisely differentiate the evaluation of this vitamin in nutrition, in fortification, and in supplementation. So it seems like we haven't really done enough research or studies yet to know the long-term effects of folic acid supplementation on the general public. This is the abstract from Reviews in Obstetrics and Gynecology, an article titled Folic Acid Supplementation in Pregnancy, More Than Just Neural Tube Defects. And it states that folate, or vitamin B9, is an essential nutrient that is required for DNA replication. Demands for folate increase during pregnancy because it is also required for growth and development of the fetus. Folate deficiency has been associated with abnormalities in both mothers and for the fetus. This article reviews the metabolism of folic acid, the appropriate use of folic acid supplementation in pregnancy, and the potential benefits of folic acid, as well as the possible supplementation of L-methylfolate for the prevention of pregnancy-related complications other than neural tube defects. So now I'd like to take a short detour and talk about something called the MTHFR gene variations or gene mutations. You can kind of relate this to the gene that determines eye color. Some 50% of people have brown eyes, that being the standard or dominant form of the gene, and anything else is a variation or a mutation of that. And that's what we're talking about with the MTHFR variations. Now, this is something still very new to science and research, and we don't know a lot about it still. But what we do know is that people with MTHFR gene mutations or gene variations metabolize or absorb folic acid or folate differently. And studies show that they're actually unable to metabolize the synthetic form of folic acid. And that what actually happens is that synthetic folic acid will clog up the receptors on the cells, and then they're not able to intake the folate from their regular diet. So many people with this gene mutation will actually become deficient in folate, which can cause serious health concerns, especially during pregnancy. Some of the health concerns associated with the MTHFR variations are neural tube defects like spina bifida and midline deformities like cleft palate and even lip and tongue ties. Some studies show that these issues might be encouraged by consuming folic acid fortified food or using folic acid supplementation during pregnancy. So going over the main points from the reviews in Obstetrics and Gynecology article, we touch on some of this information about the MTHFR variations and the possible use of alternative supplements in these situations. The main points here say that the demands for folate increase during pregnancy because it's also required for growth and development of the fetus. Folate deficiency being associated with abnormalities for both the mothers and the fetuses. Then they talk about the term folate and the different forms of it, that it is vitamin B9, one of the 13 essential vitamins, that it cannot be synthesized by the body itself. It needs to be either obtained through diet or supplementation. And then it says, based on the high prevalence of methyl tetrahydrofolate reductase, or the MTHFR genetic polymorphisms in the general population, new research in this area has focused on supplementation with L-methylfolate rather than folic acid as a means of preventing folate-related pathology. In a recent double-blind randomized placebo-controlled trial of 144 women of childbearing age, they demonstrated that supplementation with L-methylfolate was more effective than the folic acid at increasing red blood cell folate concentrations. Although additional studies are needed to better define the precise timing, dosing, and formulation, existing data suggests that dietary folic acid supplementation is a good idea for all reproductive aged women. And here, this is the conclusion from an open access text article about folic acid supplementation in pregnancy. And it says, in conclusion, folic acid should no longer be considered a one-size-fits-all supplement. More ingestion of leafy greens like kale, spinach, arugula, and Swiss chard that provide natural folate forms, including 5-methyl-THF, should be encouraged, while synthetic forms in vitamins and starch additives should be monitored. This is especially important in those carrying the MTHFR gene mutations. In these patients, it is imperative to use the active 5-methyl-THF derivative to bypass the mutated enzyme and receive the complete benefits of folic acid. Therefore, the replacement of folic acid with 5-methyl-THF in prenatal vitamins should be strongly considered as universally beneficial. So if you'd like some ways to include natural folate into your diet, here are some foods that you can eat. Mustard greens, chicken livers, asparagus, broccoli, spinach, kale, egg yolks, all kinds of options on there. And this chart gives you the amounts that you would need to get each amount in micrograms of folate. Overall, I would say this is a very important but still very controversial ingredient. And hopefully in the coming years, with more research and more studies being done, we can have more information to guide us in making educated and informed decisions about which supplements to take and how to get the right amount of folate and folic acid in our diet. Okay, moving on to iron. You might be surprised to learn that low iron is the most common nutritional deficiency in the United States. More than 10% of women are deficient in iron, according to the Centers for Disease Control. So without healthy red blood cells, your body can't get enough oxygen. This can affect your brain function, your immune system's ability to fight off infections. And if you're pregnant, severe iron deficiency can affect your baby's risk of being born too early or being born smaller than normal. And here again we have from the World Health Organization their recommendation for daily iron and folic acid supplementation. And it says they suggest 30 to 60 milligrams of iron a day. And then further into this article, it does state that if a person is severely anemic or lives in an area where dietary needs are not being met as far as iron intake is concerned, that they should take even higher amounts. And this is an abstract from an article in a medical journal titled Biochemistry Insights. And the article is Prophylactic Iron Supplementation in Pregnancy, a Controversial Issue. And this is a review of several studies. And I just want to mention, when you click on these links in the video description below, you can see the whole articles. And it will have links in the references section and throughout the article itself, wherever these studies are referenced. And some of these studies are accessible to the public for free, and some you can only see excerpts of without having a paid subscription to their database or special permissions. Now, the abstract here says that in our world today, iron deficiency is the most frequent nutritional deficiency, and it is being considered as an epidemic public health crisis. Women of reproductive age and infants are at particular risk of iron deficiency, especially in underdeveloped countries. During pregnancy, iron deficiency anemia is a specific risk factor associated with negative maternal and perinatal outcomes. Many countries have iron supplementation programs, as recommended by the World Health Organization. During pregnancy, however, iron supplementation's clinical benefits and risks are unclear. This review aims to discuss the threats and benefits of routine iron supplementation on maternal and infant outcomes. And now remember, as we start digging in here, this is a review of hundreds of different studies. All that information is combed through and compared. So when you're looking at several different studies in different places under different circumstances, sometimes you get a lot of contrasting information. And this is a lot of why I'm here highlighting this stuff for you guys, because a lot of people think, oh, they did a study and such is safe. A lot of stock is put into things without understanding how it really works. A lot of studies are flawed, or they don't take certain things into consideration. Sometimes they are done with bias or from a unique perspective. They're done under certain circumstances in different environments, different cultures, with a variety of different people. A lot is speculated, even in these scientifically designed experiments. And I promise you, for every study you can find, I can find an opposing one with just as much evidence and claim to its outcomes. You have to be meticulous and obsessive to really get ahead here and find solid answers. You have to stay up to date as more research comes out. There is no constant truth. It evolves infinitely. That's how science works. We do the best we can with the information that we have at the time. And I would strongly advise you to beware of any medical professional who does not believe this. So here we have some information pulled out of this review, and I'll touch on several of these key points here because there's just a ton of information. So this is iron supplementation in pregnancy. In many developed countries, the routine is that during pregnancy, women are advised to take iron supplements of 30 to 60 milligrams per day. In some countries, such as Australia and the UK, the protocol is to screen and supplement only those with iron deficiency anemia. A Cochrane systematic review and analysis made by the U.S. Preventative Services Task Force, or USPSTF, I'm just going to refer to them as the task force from now on, established that even though iron supplementation in gestation enhances the iron status of the mother, there are still not enough data to determine how clinically advantageous this practice is. Particularly, the task force highlighted the necessity to determine the long-term effects of iron supplementation on child development as an important area for research. Although the evidence showed benefits of early iron supplementation in women with low iron storages, it is still contradictory whether iron supplementation should be started during pregnancy in those who are not iron deficient. Some authors have observed that IS in that group has positive outcomes for the offspring. However, some studies showed that IS could lead to an iron overload. And just continuing on with this same review, this point stating, after screening 5,209 titles, they concluded that daily iron supplementation reduced in almost 70% the incidence of anemia, and little over 65% reduction in iron deficient anemia at the time of birth when compared with the control group. Daily iron supplementation during pregnancy significantly reduced the incidence of low birth weight in the intervention group by 20% when compared with the control group. Iron supplementation during pregnancy is significantly beneficial in decreasing the incidence of anemia in pregnant women and low birth weight in the offspring. Based on these studies, which were done probably in developing countries where the screening for IDA in pregnancy is very difficult, iron supplementation for all pregnant women could be considered a good strategy because it leads to a significant reduction in anemia incidences during pregnancy and thus plays a vital role in reducing maternal morbidity and mortality. This point here stating 10 trials addressed the adverse events of routine IS during pregnancy. They observed adverse effects which were mild or moderate impairment, such as nausea, constipation, and diarrhea. Generally, no significant difference was observed when comparing IS and control groups. And this point here talks a little bit about iron overload, which is one of the concerns they have with routine iron supplementation. So one of the threats of iron supplementation in pregnancy is the development of iron overload in iron replete women and in patients with diseases that lead to iron overload, such as hemoglobinopathies and hereditary hemochromatosis. And skipping to the third point, iron accumulation in the heart, liver, pancreas, and brain results in dysfunction of these organs. Free radical production due to iron overload can cause serious complicated side effects such as mental retardation, early neurological diseases, delays in sexual maturity, impotence and infertility, cardiac dysfunction, liver cirrhosis, liver cancer, hepatitis, metabolic dysfunction. Others include arthritis, chronic fatigue, depression, hair loss, change of skin color, abdominal pain, splenomegaly, venous thrombosis, and osteoporosis. So that's really a lot to think about. On one hand, the World Health Organization is suggesting routine iron supplementation for all pregnant people based on several studies that show the benefits of this, especially in areas where people tend to be deficient in this nutrient. And then on the other hand, several studies showing that this supplementation may not be as effective as we think it is, or that it may actually be harmful to some people. Although I do think that the consensus is that most of the negative side effects are very minor, except in instances where people have a pre-existing condition relating to iron absorption in the body. And here are the final conclusions drawn after the review. In conclusion, the present state of knowledge on iron supplementation for pregnant women is a debatable topic, which does have many arguments regarding the maternal and infant positive outcomes. There is no doubt that to choose a side requires not only a deep understanding of how iron is metabolized, but also both maternal and infant iron needs at different stages of pregnancy. More randomized controlled trials are needed to clarify the real impact of prophylactic iron supplementation during pregnancy, especially in developing countries, taking into account culture, geography, social and economic status, lifestyle, nutritional status, and all issues that determine health conditions in pregnancy and infancy. For pregnant women in developing countries, in situations where screening of IDA is not adequate and possible, we strongly recommend iron supplementation during pregnancy. And if you want to find some natural iron sources to enhance your diet, here are some iron-rich foods: edamame, spaghetti, cashews, lentils, almonds, watercress, spinach, Swiss chard, kale, chickpeas, cumin, turmeric, thyme, parsley, spring greens, spring onions, figs, raisins, all kinds of iron-rich foods to choose from. Okay, let's talk about zinc. Zinc plays a huge role in immune system function, wound healing, cell division, and DNA synthesis. It also helps to develop the placenta, which is what makes it so essential during pregnancy. Some studies have found that zinc deficiency can impair fetal growth. It can impact placental morphology, reduce the transport of iron through the placenta, and alter maternal blood pressure. Here's what the World Health Organization has to say about zinc supplementation during pregnancy. The overall nutritional status of the mother during pregnancy is a significant contributor to both maternal and perinatal mortality and morbidity, and improving the quality or nutrient density of the mother's diet is known to improve pregnancy outcomes. Given the limited effect observed for zinc supplementation on pregnancy outcomes, it may be more prudent to focus research on identifying ways of improving the overall nutritional status of women in low-income areas. Although there appears to be no harmful effects of zinc supplementation, the overall public health benefit of zinc supplementation in pregnancy currently appears limited. So let's take a look at some of the studies that this recommendation is based on. This is the abstract from a medical journal, the Pediatric and Perinatal Epidemiology. And it says that poor maternal zinc status has been associated with fetal loss, congenital malformations, intrauterine growth retardation, reduced birth weight, prolonged labor, and preterm or postterm deliveries. A meta-analysis completed in 2007 showed that maternal zinc supplementation resulted in a small but significant reduction in preterm birth. The purpose of this analysis are to update that previous review and expand the scope of assessment to include maternal, infant, and child health outcomes. And then skipping ahead a little bit, only the risk of preterm birth reached statistical significance. There was no evidence that supplemental zinc affected any parameter of fetal growth. The evidence that maternal zinc supplementation lowers the risk of preterm birth was graded low. Evidence for a positive effect on other fetal outcomes was graded as very low. The effect of zinc supplementation on preterm birth, if casual, might reflect a reduction in maternal infection, a primary cause of prematurity. While further study would be needed to explore this possibility in detail, the overall public health benefit of zinc supplementation in pregnancy appears limited. And here's a look at a double-blind, randomized, controlled trial about zinc supplementation during pregnancy. So it's saying the objective was to see whether zinc supplementation during pregnancy improves maternal and fetal outcome. It tells you kind of how they designed the study. Going down to the main outcome measure, various adverse outcomes were tested, including maternal bleeding, hypertension, complications of labor and delivery, gestational age, APGAR scores, and neonatal abnormalities. The main outcome measure was birth weight. And for the results, they say there were no differences whatsoever between mothers given a zinc supplement and those that were given a placebo. In conclusion, zinc supplementation in pregnancy in the UK does not seem to offer any benefits to the mother or her fetus. So from what I'm finding here, it seems that zinc deficiency is a major concern, especially during pregnancy, but it doesn't seem that supplementation is a very effective means of solving the problem. Some of these studies do suggest that getting an adequate zinc supply through our diet and preventing the deficiency in the first place could go a long way to solving these problems. Here are some zinc-rich foods to incorporate into your everyday meals. So 12 foods high in zinc. We have oysters, chicken, grass-fed dairy, cashews, watermelon seeds, that's an interesting one, almonds, spinach, asparagus, red meat, pumpkin seeds, salmon, and dark chocolate or cocoa. Now on to calcium, something I'm sure we're all familiar with. This excerpt from the American Journal of Obstetrics and Gynecology touches on the importance of calcium intake during pregnancy. It says here, calcium consumption is essential for bone development and maintenance throughout life, yet more than 1/2 of the female population in the United States does not consume the recommended amount of calcium. Calcium intake is especially crucial during pregnancy and lactation because of the potential adverse effect on maternal bone health if maternal calcium stores are depleted. Studies indicate that calcium consumption should be encouraged, especially during pregnancy and lactation, to replace maternal skeletal calcium stores that are depleted during these periods. Proper calcium consumption can be attained through the diet by consumption of dairy products or leafy greens such as kale, the consumption of fortified foods, or by supplementation with widely available calcium-containing supplement products. And here's the recommendation from the World Health Organization regarding calcium supplementation during pregnancy. And they say in populations where calcium intake is low, calcium supplementation as a part of the antenatal care is recommended for the prevention of preeclampsia among pregnant women, particularly among those at higher risk of hypertension. Based on what the World Health Organization had to say, it seems that we should be able to get the calcium we need from our regular dietary sources. Here are some calcium-rich foods to consider adding to your diet. Low-fat yogurt with fruit, sardines, cheddar cheese, skim milk, low-fat milk, whole milk, buttermilk, mozzarella, tofu, and more from that list. We have orange juice, calcium-fortified salmon, pudding, cottage cheese, spinach, frozen yogurt, kale. I think that's on every food list for every vitamin. So lots of different ways to get calcium in your diet. So as far as any negatives with calcium supplementation, there is a concern of hypercalcemia as presented by this Obstetrics and Gynecology journal from India. Hypercalcemia is rarely encountered in pregnancy. The commonest cause of hypercalcemia in pregnancy is hyperparathyroidism. It is associated with significant morbidity to the fetus and mother in more than 2/3 of cases. Adverse fetal outcomes include increased rate of abortions, severe intrauterine growth retardation, and stillbirth. Parathyroid hormone levels are low to mid-normal in pregnancy, and higher than normal values in the background of high calcium may point to the diagnosis of primary hyperparathyroidism. So overall, calcium is very good for us, very necessary, especially during pregnancy. And since our bodies cannot make it on their own, we need to make sure that we get plenty of it through our diet or adequate supplementation. Another common ingredient in many prenatal vitamins is vitamin D. Vitamin D plays an important role in immune system function, cell division, and bone health. It is also necessary for the metabolism and absorption of calcium and phosphorus. First, let's see what the World Health Organization has to say about vitamin D supplementation during pregnancy. Vitamin D is known to play an important role in bone metabolism through regulation of calcium and phosphate equilibrium. Vitamin D is produced by the body during exposure to sunlight, but is also found in oily fish, eggs, and fortified food products. Vitamin D deficiency is thought to be common among pregnant women in some populations and has been found to be associated with an increased risk of preeclampsia, gestational diabetes mellitus, preterm birth, and other tissue-specific conditions. Vitamin D supplementation during pregnancy improves maternal vitamin D status and may reduce the risk of preeclampsia, low birth weight, and preterm birth. However, the evidence currently available to directly assess the benefits and harms of the use of vitamin D supplementation alone in pregnancy for improving maternal and infant health outcomes is limited. Pregnant women should be encouraged to receive adequate nutrition, which is best achieved through consumption of a healthy, balanced diet. So their recommendation here at the bottom says that vitamin D supplementation is not recommended for pregnant women to improve maternal and perinatal outcomes. Okay, so according to this, there's a definite need for vitamin D before and during pregnancy, but the World Health Organization doesn't find sufficient evidence that supplementation alone can make improvements on these issues. But as we've already learned, we often need to consult several sources to get a well-rounded view of the whole situation. So let's take a look at some studies and reviews to get a better understanding. So here we have a screenshot from the Cochrane database where they've done a review of several different studies and have checked them for accuracy. The background, vitamin D deficiency or insufficiency is thought to be common among pregnant women. Vitamin D supplementation during pregnancy has been suggested as an intervention to protect against adverse gestational outcomes. So just skimming through the main results here, they went through several different studies. They say only one trial with 400 women reported on preeclampsia. Women who received 1,200 IU of vitamin D along with 375 milligrams of elemental calcium per day were as likely to develop preeclampsia as women who received no supplementation. 4 trials involving 414 women consistently show that women who received vitamin D supplements had higher concentrations of vitamin D in serum at term than those who received no intervention or placebo. No studies reported on preterm birth, maternal death, admission to neonatal intensive care unit, special nursery, or APGAR scores. So the conclusions here that vitamin D supplementation in a single or continued dose during pregnancy increases the serum vitamin D concentrations that measured. So that's like what's in your blood level at term. The clinical significance of this finding and the potential use of this intervention as a part of routine antenatal care are yet to be determined, as the number of high-quality trials and outcomes reported is too limited to draw conclusions on its usefulness and safety. Further, rigorous randomized trials are required to evaluate the role of vitamin D supplementation in pregnancy. So this says that we don't have a lot of evidence yet to support regular supplementation of vitamin D during pregnancy. So this is an abstract from the Indian Journal of Endocrinology and Metabolism. And it says, obstetric endocrinology is a field characterized by opportunity, challenges, and caution. Opportunity because the antenatal period presents a window during which endocrine and metabolic manipulation can impact not only maternal and fetal health, but also long-term outcomes in offspring. Caution is necessary too, because the same therapy may lead to unwanted adverse effects in the innocent fetus and have, as yet unknown, long-term complications. Challenges in obstetric endocrinology are unique too, as ethical and practical issues make it difficult to conduct randomized placebo-controlled trials in many situations. So that gives us a little insight as to how many unknowns there really are in the endocrinology field, especially as it relates to pregnancy. We still have very little research and evidence to support a lot of the ideas that are out there. And the conclusion from that same journal: as we mentioned initially, obstetric endocrinology is a field marked by both opportunity and caution. With the available evidence regarding vitamin D supplementation and the conflicting interpretations of whatever has been published, it becomes challenging to issue evidence-based guidelines. However, the benefit of vitamin D supplementation in pregnancy is potentially even greater than the non-pregnant state. Yet, we continue to prescribe lower doses to pregnant women than to their non-pregnant peers, perhaps because of an unfounded fear of the side effects. Symptomatic or documented vitamin D deficiency in pregnant women should be treated in the same manner as in non-pregnant individuals. And then skipping to the last section here, as in other fields of obstetric endocrinology, there's an urgent need for greater research in vitamin D therapeutics in pregnancy. While we wait for more robust data, we should continue to supplement this nutrient in all pregnant women from the 12th week of gestation onwards. So even though they say they don't have solid evidence to support the theory, they still recommend supplementation, especially in deficient women. But do remember the source of these studies, and that many of them are done in areas where vitamin D deficiency is very prominent. And last, we have a study that references the concerns that we may have with taking too much vitamin D. And this is from the Journal of Clinical Medicine, and it's hypercalcemia associated with calcium supplement use, prevalence and characteristics in hospitalized patients. Now, remember, we did touch on hypercalcemia back when we were discussing calcium supplementation, but it applies to vitamin D supplementation as well. And the abstract here, the background: the ingestion of large amounts of milk and antacids to treat peptic ulcer disease was a common cause of hypercalcemia in the past, and the current popularity of calcium and supplements has given a rise to a similar problem. So they want to evaluate the prevalence and characteristics of hypercalcemia induced by calcium intake, or calcium supplement syndrome. The conclusion: the widespread use of calcium and vitamin D supplementation can manifest as hypercalcemia and worsening of kidney function in susceptible individuals. Awareness among healthcare professionals can lead to proper patient education regarding these health risks. And here the conclusion from that review: CSS is of potentially significant public health importance. Calcium and vitamin D supplementation is thought to have general health and preventative benefits, and it's also recommended for the treatment of osteoporosis and vitamin D deficiency. However, it's becoming evident that liberal calcium intake in susceptible individuals may not be entirely benign, with consequences not unlike the classic milk alkali syndrome of the past. Awareness of its health implications should alert patients and clinicians alike to the dangers of excessive or indiscriminate use of calcium and vitamin D supplements. So overall, I'm finding that we still need more information on the topic to get solid answers. Is vitamin D important? Definitely. But can we get enough of it through food and sunlight exposure? Here are some natural ways to increase your vitamin D levels: cheese, fortified milk, egg yolk, mushrooms, and fatty fish for foods, and then sunlight. Maybe people in certain areas where the exposure to sunlight isn't sufficient or the dietary needs are not being met, supplementation could be a great idea. As always, you'll want to weigh the pros and cons and make the choice that best suits you. Another common ingredient in prenatal vitamins is vitamin C. Vitamin C is necessary for the body to make collagen, which is a component in making cartilage, tendons, bones, and skin. Based on animal studies, some researchers believe that vitamin C deficiency in newborns can impair mental development. Also known as ascorbic acid, vitamin C is essential for tissue repair, bone growth and repair, wound healing. Vitamin C helps your body fight infections and works as an antioxidant. So what does the World Health Organization have to say about vitamin C supplementation during pregnancy? So here are the World Health Organization's key findings. They say few trials were conducted in women with inadequate vitamin C intakes or low vitamin C status, and thus the effect of vitamin C supplementation during pregnancy in these populations remains unclear. Supplementation with vitamin C and vitamin E during pregnancy reduced the risk of placental abruption. Vitamin C given alone reduced the risk of preterm and term pre-labor rupture of membranes, while the risk of term premature rupture of membranes was increased with vitamin C was provided together with vitamin E. Overall, no effect of vitamin C supplementation was found for the outcomes of preterm birth, preterm or term premature rupture of membrane, preeclampsia, stillbirth, neonatal death, perinatal death, or intrauterine growth restriction. Current evidence does not support the routine use of vitamin C supplementation during pregnancy. Again, I'm finding that the evidence just is not there to support routine supplementation of this vitamin. Most importantly, we don't have any studies on women who were deficient in vitamin C before they received the supplement, which makes it difficult to assess the positive outcomes in this scenario. Just more illustration of the issues with studies and trials during pregnancy. It's an issue of ethics and safety, and seeing all sides of an issue is nearly impossible with those limitations. Here's a Cochrane review about vitamin C supplementation during pregnancy. And they say, what evidence did we find? This review included data from 29 trials involving over 24,000 pregnant women from 17 different countries. The findings indicated that routine supplementation with vitamin C during pregnancy, either alone or in combination with other supplements, mainly vitamin E, did not improve outcomes for women and their babies. There was a 36% relative reduction in the placenta coming away early from the uterine wall, otherwise known as placental abruption, in women given vitamin C supplementation. This was rated as high quality evidence. However, it was unclear whether this finding was due to vitamin C or another agent, as most trials gave women vitamin C combined with vitamin E. In the studies that gave women vitamin C only, there was a reduction in pre-labor rupture of the membranes occurring either preterm or at term. However, there was an increased risk of premature rupture of membranes in the studies that gave women vitamin C and vitamin E combined. Therefore, further research is required to examine the role of vitamin C in reducing placental abruption and the development of premature rupture of membranes. The review found in one study only an increased risk of abdominal pain with vitamin C, indicating there may be harms associated with vitamin C supplements in pregnancy. So I looked at a lot of studies concerning the harms or the cons of taking too much vitamin C during pregnancy, and they all kind of came down to the same conclusion, that it's very difficult to even have too much vitamin C in your body due to the way that it's metabolized. We only use what we need, and the rest is excreted in waste. The most common side effect of high vitamin C intake seems to be nausea and upset stomach. There are very rare chances of more serious concerns like kidney stones, nutrient imbalances, and bone spurs, but these are very uncommon and usually associated with other underlying conditions as well. As it seems with so many of these ingredients, if we start out with a healthy diet, we can eliminate a lot of the deficiency to begin with. Here are some natural ways to get vitamin C in your diet. So we all know that oranges have a ton of vitamin C, but here's some more foods that are high in vitamin C. Red peppers, yellow peppers, strawberries, kale again, broccoli, kiwi, spinach, always on the list, cauliflower, cantaloupe, all kinds of different foods that you can incorporate into your diet to get lots and lots of vitamin C. And now last but not least, let's move on to vitamin B6. This nutrient seems to be most commonly used to treat nausea in pregnancy, but it is also used in combination with iron supplements to treat anemia in people who are also B6 deficient. B6, also known as pyridoxine, is essential for the development of your baby's nervous system and brain, but it also has some benefits for you as well. Part of its role in the body is to produce norepinephrine and serotonin, two essential neurotransmitters, which aid a whole host of metabolic functions. And I bet you guessed it, the first thing we're going to look at is what the World Health Organization has to say about B6 supplementation during pregnancy. So here we have it. The recommendation is that vitamin B6 supplementation is not recommended for pregnant women to improve maternal and perinatal outcomes. Remarks below say that pregnant women should be encouraged to receive adequate nutrition, which is best achieved through consumption of a healthy, balanced diet, and to refer to guidelines on healthy eating. They say there is insufficient evidence on the benefits and harms, if any, of routine vitamin B6 supplementation in pregnancy. However, research on the effects of routine vitamin B6 supplementation for pregnant women on maternal and perinatal outcomes is not considered a research priority. Again, the World Health Organization is suggesting we get this vital nutrient through regular diet and adequate nutrition. and no recommendation for supplementation during pregnancy. However, there may be some exceptions to this recommendation. This is an excerpt from the European Journal of Clinical Nutrition talking about the role of B6 in treating anemia in some patients. Here we have the abstract where they state iron deficiency is the most common cause of anemia in pregnancy. Pregnant women with anemia are, in general, exclusively treated with iron supplementation. We observed that several pregnant women with anemia who were non-responsive to iron supplementation also had a vitamin B6 deficiency, and that anemia in these cases improved with the administration of vitamin B6. We conclude that it is important to take into account the deficiency of vitamin B6 besides iron in the evaluation of anemia during pregnancy. And the results from that review, among the 56 anemic pregnant women with vitamin B6 deficiency, iron supplementation had already been begun in 24 women without confirmation of iron deficiency, with no improvement of anemia. Although these subjects were non-responsive to iron supplementation, anemia improved with vitamin B6 treatment with a daily dose of 75 milligrams. So it does seem there's an argument for B6 supplementation with an anemic patient who is B6 deficient. This study does also mention that B6 deficiency is more common in the second and third trimester, showing a possible link between vitamin deficiency and pregnancy itself. As far as too much B6 during pregnancy or negative effects of B6 during pregnancy, all of the studies I could find seem to find no negative links between B6 consumption and pregnant people. Even large doses have been deemed to be safe by many reviews and studies. Here's an example of a review in the Journal of Obstetrics and Gynecology. And this is titled Pregnancy Outcome Following Use of Large Doses of Vitamin B6 in the First Trimester. And they say vitamin B6 is often prescribed for the treatment of nausea and vomiting of pregnancy at much higher doses than initially recommended. Large doses of vitamin B6 have been associated with cases of neuropathy. We set out to assess whether higher than standard doses of vitamin B6 during the first trimester of pregnancy were associated with a risk of maternal adverse events, major malformations, miscarriages, or low birth weight. This was a prospective, comparative, observational study. There was no statistical differences in the study endpoints between the vitamin B6 and the control groups. Within the limits of our sample size, higher than standard doses of vitamin B6 do not appear to be associated with an increased risk or major malformations. Overall, I feel the evidence on this one points to B6 being helpful for nausea during pregnancy and maybe helpful for those who are anemic and also have a B6 deficiency, but that supplementation across the board may not be necessary. We might be able to obtain enough B6 through our regular diet. So here are some ways to obtain B6 naturally. So lots of options here. I'm not sure why it says beans over that chicken, but we're just going to ignore that. Cooked pork, salmon, lean beef, bananas, sunflower seeds, prunes, spinach again, dried apricots, and tuna. All good ways to get your B6 vitamin. So lastly, which vitamins should you take? Personally, I cannot find one single pill on the market that would fit my own interpretation of these studies and recommendations. I would feel best about taking individual supplements of the nutrients I felt I needed, rather than a complex that may have adverse effects or just may be unnecessary for me. You have to make your own choice, obviously, but I'll link below some of the brands that midwives and other people in the childbirth community that I know and trust recommend. And on that note, let's wrap it up. Feel free to leave any questions or comments below. I'm always open to discussion and I would love your feedback and interaction with this video. I hope that I covered the things that are important to you and answered all of your questions. I know that this all seems like a lot to digest, and it is, as it should be. This is one of the most important experiences of your life, and you should not go into it blindly. I hope that you will use the information in this video, the links below, and your own independent research to make informed and educated decisions. Thanks for watching. Don't forget to like this video, share it with your friends, and most importantly, subscribe to stay up to date on my latest videos.